Dear urologists, good evening one and all. On behalf of the Association of Southern Urologists, our ASU President Dr. Changal Mohan sir is attending emergency EC meeting of Urology Society of India. That's why he conveyed that to conduct the program by Honorary Secretary by myself, Dr. Chandra Mohan. Dear members, as you all know, the Association of Southern Urologists is rapidly growing. A lot of PG seats are available and they are getting converted to consultants once they pass the PG. I request before starting the symposium today, with the permission of the moderator, Dr. Raghunath, that all the urologists, they will pay the money to become ASU member, associate member before they clear the MCH or DNB exam. They all know that after passing the MCH or DNB, they need not pay any extra amount to become the member permanent, just by submitting the provisional pass certificate from the registrar office. This one should be able to do by themselves, and it is very simple. In the website, you can go and start membership. Everything comes in a flow. So I request kindly become full members, make the society bigger, and avail the benefits of all the benefits of permanent member of Association of Southern Urologists. With this, I like to say that first few months we have done one-to-one talk where I was interacting with single speaker. I thought a lot of urologists are there in the present ASU, so that every month we will conduct a symposium on one topic, so that at least 7 to 10 members of the ASU members will get chance to present. So I requested Dr. SK Raghunath with a short period of notice. Immediately he responded and said that I will conduct the symposium on Organ-Confined Carcinoma Prostate. Without wasting time, I will introduce Dr. SK Raghunath, who is well-known member of Association of Southern Urology. For those juniors who doesn't know him, he is MBBS from Government Medical College, Mysore, MS General Surgery from Government Medical College, Mysore, DNB from MPUH Nadiad, Fellowship in Uro-Oncology, Rajiv Gandhi Cancer Institute and Research Center, Fellowship in Laparoscopic Robotic Urology 2007 at Tapai City Hospital, Mackey Memorial Hospital, Taiwan, Fellowship in Molecular Oncology for Prostate Cancer in 2013, and Walter Reed Army University in Maryland, Washington in the 2003 same year. He is one of the few uro-oncologists who has performed many robotic uro-oncology surgeries, more than 500. He has been invited as faculty for more than 100 conferences in India and abroad, including EAU in 2017 at London, 2018 at Copenhagen, and SIU. He has organized more than 20 conferences, live operative workshop, and symposium on prostate, kidney, and bladder cancer. Dr. Raghunath has more than 20 national and international publications to his credit. He also authorized quite a few uro-oncology book chapters. In fact, he is close friend of me. We are very close friends and communicate each other. He has a lot of interest in teaching, and he is contributing a lot of teaching in the South, not only in South Zone and in the national level, also for the PGs especially. He selected good speakers today. Just to name, after that Raghunath will introduce Dr. Prashanth from Hyderabad. He will present at the end. Due apology because he had emergency right now. Dr. Arun Menon from Kerala. Dr. Rakesh Sharma, again a very well-known uro-oncologist from Hyderabad and very good surgeon and knowledgeable person. Dr. Srivatsava, Dr. Gopi Chand, who is again my close friend from Hyderabad, who works on uro-oncology with early person who started robotic oncology surgeries in Hyderabad. Dr. Srinivasam Chilkuri, radiation oncologist, and Professor Nikhil Vasudeva, as suggested by Raghunath sir. We will have a insights into the surgical aspects a bit. And the moderator, none other than Sanjai Addla, who is my classmate in MBBS and a very knowledgeable person about uro-oncology, with the panelists Ginil Kumar, Raghunath, Ananthakrishnan Sivaraman, Santosh Kumar, Ragavan, and myself. So with this introduction, I will hand over the program, and Raghunath, only request is, please remember the last speaker also when you are speaking. And moderator Sanjai Addla also should be given time. So confine yourself to time. And participate by adding a chat box, because in Zoom, we cannot unmute everybody. If any senior is there, you can raise your hand. We will unmute if possible. Kindly cooperate with this. Thank you very much. Over to Raghunath sir. Raghunath sir, your voice is not audible. Just 1 second, sir. Just 1 second. Arun sir, are you listening to him?
No, I cannot hear him, sir.
Yeah, we are not listening to you. Just wait a minute, sir. Raghunath sir, can you unmute or mute or? Full?
Is Dr. Raghunath audible?
Sir, we are not able to listen to you, sir. It's a waste. Either you rejoin quickly. Call, sir. We are not able to call by.
Sir, he's saying, please continue. Start off.
Yeah. In that case, I am sorry. I will start with the first topic, because this is academic forum. We don't want to waste the time. That's what probably is conveying. He will join back. First topic is beyond the basics, advances in imaging techniques for prostate cancer staging and treatment planning. As you all know, MRI, now urologists also have to know. Everybody is reading T2 weighted images. Everybody is reading other images, contrast images. So let us see all aspects of imaging techniques by Dr. Arun Menon. Over to you, sir, please.
I'll just share my screen, sir.
Yes, sir. We are able to see you. Your screen. We have already participants, around 80 participants already. We have already given YouTube link also, so that more will be there.
Okay.
You can make full screen, sir.
Yeah. I hope this is okay, sir.
Yes, sir. Yes, sir. Thank you.
Okay. Sure. I'm just going to start off. Thank you for this opportunity, sir. So my topic is basically beyond the basics, advances in imaging technology for prostate cancer staging and treatment planning. So where we were, staging of the primary and nodal and metastatic staging. So actually about 10 years back, we used to see metastatic cancers and some low risk cancers. So primarily we used to do rectal examinations to make sure that the tumor is still operable. And we used to do something like a mapping biopsy, where we have these cores in multiple areas, the left and the right of the prostate, the base and the apex. And we used to make treatment decisions based on this mapping, whether to spare the nerve. Obviously, on this patient, we couldn't spare the nerve on the left side. How aggressive we need to be on the apex. Can we do a bladder spare? All these we used to based on this. We actually never used to do MRIs because the MRIs were of very poor quality. They really wouldn't change management. And staging evaluation was bone scans and either CT of the pelvis or the MRI of the pelvis for nodal metastasis. So we've kind of transitioned from that for T staging to MP-MRIs and to PSMA PET CTs. So metastatic evaluation per NCCN guideline is actually required for intermediate unfavorable or above. So my talk in this next 8 minutes, it's going to be, I'm going to try and cover what I can about staging the prostate, T-staging and metastatic evaluation. So coming to staging of the prostate, the standard of care today is multi-parametric MRI, which is basically T2-weighted imaging with a diffusion-weighted imaging, ADC, with or without dynamic contrast enhanced imaging, which is a biparametric MRI. T1-weighted imaging is basically for regional lymph nodes and to assess skeletal metastasis and to also assess artifacts in the prostate. T2-weighted imaging is what is used for anatomical
if you don't
evaluation.
mind, a little slow, sir. Even I am not
Okay.
able to, no problem. 1 or 2 minutes this way or that way, little slow, please.
Sure. So T2-weighted imaging, it's basically for morphological imaging of the prostate for extracapsular to evaluate extracapsular extension or seminotic elevation. It provides a good anatomy of the zonal structure of the prostate. It's useful for volume determination. And areas suspicious of prostate cancer will appear hypointense. Basically, T2 imaging, we all know, water content appears white. So in the cells that prostate cancer is very cell dense. So there's very little fluid there. So it appears darker compared to the normal appearing areas. Diffusion weighted imaging, the prostate cancer appears, on the whiter hypointense side. And ADC, it appears hypointense. Again, this is basically using the water content of the prostate cancer cells, which is less. So diffusion weighted imaging causes these cells to appear in these two protocols. Finally, we have dynamic contrast enhanced imaging. Basically, the prostate cancer has a lot of neovasculature. So there's early contrast uptake and early washout also. So if you, it's particularly useful when the DW and the T2-weighted imaging are substandard. And it's already transitioned to biparametric MRI, which does not include the sequence. You can skip the contrast. So we're all familiar with this PIRATS grading of prostatic lesions. So if we have good MP-MRI, why are we trying to innovate more in these regions? So there are a couple of reasons. One, there's a significant difference in MRI reporting among radiologists. For a radiologist to be well versed with MRI reporting, he has to have some amount of training and some experience in reporting early prostate cancer. Second, the DWI and ADC images are very prone to artifacts, bowel gas, multiple artifacts can cause reading to vary. And finally, we need to focus our imaging studies on diagnosing clinically significant prostate cancer. We really do not want to find autopsy cancers or non-significant cancers. So that's where this microstructural imaging techniques come in. These are all investigational and they're not really in use in clinical studies, in clinical practice yet. So I'm going to cover a few of these. The hybrid multi-dimensional magnetic resonance imaging, the verdict, luminal water imaging, and magnetic resonance fingerprinting. So, mouthful hybrid multi-dimensional MRI is a novel MRI technique that characterizes tissue microstructure by measuring the change in T2 and ADC in response to changes in echo and B value. Sounds fancy. Basically, what it does is it can quantify the amount of lumen, stroma, and epithelium. So you have a map of the prostate. In addition to your MRI, your standard protocols, you have this map of cellular structures: stromal volume, luminal volume, and epithelial volume. And as you can see over here, the red area where there is an increase in epithelium, it corresponds to the dark area on the ADC. So it signifies clinically significant prostate cancer over there. verdict.
Primarily MRI image, sir. This is primarily MRI image.
Yeah, for T staging, MRI, advances in MRI image.
This image is produced by MRI mission.
It is produced by MRI mission.
Okay.
The verdict it's a short form acronym for vascular, extracellular, and restricted diffusion for cytometry in tumors. It's an imaging technique that builds on diffusion weighted imaging. And basically, it again describes diffusion signals in 3 separate populations. The water molecules trapped inside cells, in the interstitium and inside blood vessels. And it creates an intracellular volume fraction. So as you can see on that image, the area where you have a maximum number of intracellular volume, which is basically cell-dense prostate cancer. You have that red area, which corresponds to the suspicious areas on the other protocols. Luminal water fraction imaging, it distinguishes the luminal spaces of the prostatic epithelium from stroma and epithelia. The luminal space is reduced in prostate cancer. So it again appears much more dense here. And the advantage for this is that it is actually based on T2 weighted imaging rather than diffusion weighted imaging, which is prone to artifacts. And finally, magnetic resonance fingerprinting. So this is exactly like putting a fingerprint. Basically, what it does is it stretches the prostate and looks at the relaxation time. So ideally, the relaxation time in the normal areas is actually runs into a few microseconds. When you have prostate cancer, it's a very dense area. So the relaxation time is actually much shorter. So again, there is a suspicious area in the peripheral zone over here. And the relaxation time of that was actually quite short compared to the remaining prostate gland. So that was about T staging. Now coming to nodal staging and distant metastatic evaluation. So we've been through this, this whole line of investigations. We used to do CT or MRI pelvis for nodal evaluation. Subsequently, we went to for evaluation of bone metastasis. We used to look at our bone scans, MDP bone scans, whole body MRI or CT. And finally, the flucyclovin oxymin scan or choline scan, which were never really popular. So now we have the PSMA receptor. Sorry, the PSMA receptor, which is a transmembrane receptor. It is present in normal healthy prostatic epithelium, and it's overexpressed in prostate cancer. So the PSMA receptor, it accepts these PSMA ligands, which is the PSMA 11 or PSMA 617, which are bound to radiopharmaceuticals, the gallium in diagnostic imaging, and lutetium in theranostics. And what happens is this is actually internalized. It's endocytosed, and that causes DNA damage. So that's the advantage in theranostics there. So these are the different radiopharmaceuticals that have been used: PSMA 11, PSMA INT, 18 fluoride DCF PYL or Pylarify, and PSMA 1007. So what is there any particular advantage of any of these? None have been proven to be particularly advantageous over the other in any study.
What is the commonly used, sir? What is the commonly don't mind, because at the end discussing looks bore. That's why I'm interfering. Sorry.
Sure.
From the PG's examination point of view, PSMA PET CT means what? You have mentioned.
We use the gallium, 68 gallium.
Yeah.
PSMA 11.
68 gallium.
Yeah.
Okay. So, do the cost differ with this when you are doing in the private practice? Are they available other things in India?
No, actually, from what I know.
Can you go to previous slide, sir? Can you go to previous slide? Like you have mentioned GA-PSMA 11, GA-PSMA. Which one is used in India? Which one is
11? 11 is used in India.
68 GA-PSMA 11 is used.
11 is used.
Yeah. Okay.
So the only stark difference between these is how these are excreted. PSMA 11 is actually excreted through the kidneys into the bladder.
Okay.
And PSMA 1007 is actually through the liver. So why that makes a difference is, so although I've listed all these differences, the only one that matters to us is actually because this is excreted through the liver and gallium is excreted through the bladder, diagnosing recurrence in the prostatic bed is actually, there might be a slight advantage with PSMA, 18 fluoride PSMA 1007. But again, even with gallium, there are ways to get around it. You can diurese the patient, you can ask him to void, you can take late scans. So there are imaging.
Are there any areas where it cannot detect this PSMA PET CT? Is there any tissues which it cannot detect as static evaluation?
In metastatic evaluation, when the cells do not express PSMA, it might not detect it.
Okay.
So the European Association of Nuclear Medicine has proposed a TNM staging. It's called the molecular TNM staging. And there are actually a lot of criteria to it, which is actually based on something called the PROMISE guidelines. There's a primary score and a PSMA expression score. All we need to know is it's actually all based on the blood, the uptake in the liver, and the uptake in the parotid gland. And this is the molecular staging. It is actually just a mirror of our regular TNM staging. So what are the newer avenues in PSMA scans? So long axis field of view scanners. Yes, sir.
Arun?
Yes, sir. I can hear you, sir.
Yeah, we can hear you, sir. Continue, Arun, sir.
So long axis field of view scanners, they increase detection of gallium PSMA 11, and they are able to do this with late imaging without loss of image quality, which is a huge advantage in biochemical recurrence. Like I said, it's excreted through the bladder. So you want the patient to empty the bladder before you do a scan. By that time, the radioactivity might actually wean off. So with these scanners, that's actually avoided. And you can actually decrease the amount of administered radioactivity. The total radiation dose is much lower than with a regular scan. So PSMA scan, any advantage in T staining? It's complementary to MRI, and you're more likely to pick up clinically significant prostate cancers. And it's particularly useful when an MRI is contraindicated or the patient has claustrophobia. You can just do a PSMA PET CT. You will get a general idea of what the stage is. For N staging, it is definitely more sensitive than the CT or the MRI. But again, sensitivities are quite low. It's just around 41% in radical prostate patients, and specificity is around 95%. But so it cannot replace pelvic lymph node dissections. In biochemical relapse, PSMA scans are recommended when the PSA goes over 0.2. The sensitivity increased to about 70% or so in that range. And multi-parametric prostate bed MRI is complementary. It can detect prostatic bed disease. And post-radiation therapy, it can guide local salvage treatment, and it's complementary for detecting PSMA relapse and distant disease, PSMA PET CT. CRPC, it is useful in assessing disease status, progression, evaluation of treatment response. So what are the newer pharmaceuticals, especially in CRPC, when you have poorly differentiated cancers that did not express PSMA, or when a long duration of ADT has been given and the cells kind of the ADT can cause the cells to kind of change their PSMA expression, or when there's neuroendocrine differentiation. In these instances, you need to use other radiopharmaceuticals like FDG. Then there are androgen receptor targeting imaging, which again, this is not in clinical practice. It's 18 fluoride fluoro-5-alpha dihydrotestosterone. So the advantage of this is if the patient has avid disease on this radionuclide, you can probably treat him with an anti-androgen like enzalutamide. And neurotensin receptor 1, it's also highly expressed in androgen-independent prostate cancer cells. So that's androgen-independent radiotracer.
Arun, how many more slides are there?
They can be. I'm done, sir. Actually, I'm done. Just one or two more slides. That's all.
Yeah.
The pitfalls, there are benign regions of benign uptake, non-specific where other cancers can take up, and there are false negatives. And again, artificial intelligence is coming into this field as in all other fields also. So all the data that we get through diagnostics and treatments, they are used to generate AI algorithms. which can use for data, image acquisition, image interpretation, reporting, and management. So take-home points: multiparametric MRI for T-staging and PSMA PET are standard of care. New generation scanners, long axis field of view, can improve on current PSMA PET CTs. And novel radiopharmaceuticals are in the pipeline. And one key point is, are we really getting a survival benefit by doing these super sensitive scans? That remains to be answered. Thank you.
Thank you, Dr. Arun. We are running behind schedule. Sorry for this. So we'll move on to the next topic.
Sir, two questions I will ask, sir, if you don't mind. Arun, sir.
Yes, sir.
Nowadays, before doing the prostate biopsy, we are all doing MP-MRI. If we are planning for surgery in prostate cancer, do you recommend PSMA PET CT in all the patient or PET MRI also, whatever it may be? Previously, we used to do bone scan before going for surgery. Now, is it, even if it is localized disease, is it recommended to do PSMA PET if it is available?
So the answer to the question is, sir, per NCCN guideline, only intermediate, unfavorable, and beyond, you need to do a metastatic evaluation. But unfortunately, in India, there's a lot of heterogeneity in how to characterize these patients. For example, a pathologist might read a 3+4, our pathologist might read it as 4+4. So to avoid that, to be on the safer side, it's better to do a PSMA PET CT.
Second question, after that, I will hand over to Raghunath. In MP-MRI, is the contrast is given in all the cases or not?
No, you have a biparametric MRI where we can skip the contrast.
Okay, thank you, Raghunath sir. Over to you.
Yeah, thank you, Dr. Arun.
I apologize for the time, sir.
We'll move on to the next topic by Dr. Rakesh Sharma. Welcome, Dr. Rakesh Sharma. He is going to speak on genomic insights in prostate cancer. Over to you, Dr. Rakesh. And sincere request, I request all others to mute, and other than speakers, you can switch off your videos also. Thank you.
Yeah.
Over to you, Dr. Rakesh.
Yeah. Good evening, chairpersons. Thank you for the opportunity. So I'm going to speak on genomic insights in prostate cancer, personalized risk stratification, and future potential. So as we all know by today that prostate cancer is largely a heritable and polygenic disease.
Okay, sir, can you make the slide full?
It's full, sir, at my end.
No.
No, it is not. Make it full screen. Make it full screen.
Yeah.
No, sir?
No,
No.
not.
Make it full screen.
Second.
No, in his, we can see it, there is no problem, but those who are seeing.
But make it full screen.
1 second, I'll do it again.
Request others to switch off your video also, please. Thank you.
It's okay, sir, visible.
Yeah.
No problem.
Now, sir? Not yet?
It's still.
I'm sorry, it's not happening.
No problem, please.
So genomics can increase the efficiency of prostate cancer screening by focusing on those with genetic predisposition for cancer, which can be combined with the risk factors, which we already know, like the age, ethnicity, and can be used for risk stratification in risk-based screening, and basically for the treatment of like locally advanced prostate cancer. And we already know, like in the metastatic stage, like the CRPC and all, we are already utilizing this genomic studies. So starting with the screening, the goal of the risk-based screening is to facilitate early diagnosis of the clinically significant prostate cancer and reduce the overdiagnosis or overtreatment in those unlikely to experience a prostate cancer-related symptoms in their lifetime. So genetic testing can guide prostate cancer management by identifying those at the risk of lethal prostate cancer and enabling the access to novel targeted therapies. So what is a mutation? Basically, there are two types of mutation, a germline mutation and a somatic mutation. To simplify it, so any change in the DNA sequence which are inherited from the parents is called germline, and anything which happens other than that, like within any organ, like in the prostate, it starts in the prostate and there is a DNA sequence change, then it is called as the somatic. Okay, so majority are somatic, few are the germline.
Rakesh, sorry to interrupt. Your slides are not moving.
Not moving?
No.
Yeah. Yeah, now they are moving.
They are moving. Again, I will start sharing, sir. Sorry for that. Is it visible now?
Yes.
Slides are visible?
Yes, yes.
Is it full screen now?
No,
No,
no.
not yet. Not yet.
I don't saw at my end it is showing full screen, sir. Sorry for that. So
Okay.
for the
So please go ahead.
established,
Please go ahead.
yeah, for the established risk factors, we have the age, the family history, and the ethnicity. So age, we know beyond 60, 65 years, there is a higher incidence of having a prostate cancer. Family history, more than 2 family members who have been diagnosed with prostate cancer, or one of the family members who have died with prostate cancer, they carry a higher risk, and they are considered in the high risk group. And ethnicity is the African American Africans, they are the higher chances of developing prostate cancer. So these are the established risk factors we know. And the genetic predisposition, we have the 3 types of the variants. One is unexplained, which is around 48%. The second is the common variants, that is the GWAS, the Genome Wide Association studies of almost like 451 genes are there. And here there are rare genetic variants, which are the common ones. We know that the BRCA2A1, BRCA2A1 and the HOX, the ATM, the CHEK2, PALB, all these are there. So the common variants, mainly coming on to common variants, they are found only in 1% population, and they are in combination with the other, they can increase the risk of the clinically significant prostate cancer. The cumulative effect of these 451 risk elevating SNPs known to be associated with prostate cancer are generally used to generate a PRS.
Sir, slides move, sir.
Sir, at my end, it is moving, sir. Now?
No.
Now try selecting that particular slide and
I'm doing that.
click on that particular slide and see.
Slide instead of using the button.
Yeah. So,
yeah, now it is full screen.
Yeah. So polygenic risk scores are generally what's called as the PRS. It predicts a person's lifetime risk of cancer based on their genotype, and it is generated for any disease, let it be cancer or cardiovascular, pulmonary problems, anything, a PRS can be generated. And the cancer risk represented by the PRS is generally derived from the disease associated with the SNPs, the single nucleotide polymorphism only, and not a single gene variant like the BRCA1 or 2 like that. So the sum is the score of all the alleles across the PRS, and each one are labeled as log ORs, and they are estimated like that. So the score will finally come in this PRS. And the rare variants are the 1 to 2% of the people with prostate cancers, and they are the autosomal dominant DNA repair gene variants or the mismatch repair variants. So the literature says 10 to 15% of advanced prostate cancer have a constitutional pathogenic variant that is likely to be causative, with up to 25% in somatic samples from metastatic CRPC. But that is generally we don't see. This is what is a figure. What the Lee et al. Has mentioned is what is seen in the real life picture. And most of these patients, they have either node positivity or they have a higher Gleason score of 9 to 10. So patients with the BRCA2 and the ATM gene are associated with more aggressive prostate cancer. And the worst is the BRCA2, where there is almost like 7.5 to 8.5 fold increased risk of developing an aggressive prostate cancer. So these are the increased risk of prostate cancer for more of these common variant genes what we see. So the BRCA2 and the 1 are the highest, followed by the ATM. Then when we see a comparison with the non-carriers, for the BRCA2, the younger onset, the higher stage, T stage, and the higher Gleason, more lymph node involvement, shorter prostate cancers, specific survival and OS are seen. For the BRCA2 and the BRCA1 ATM, we see 4-fold higher risk of lethal prostate cancer and shorter overall. So they are all aggressive genes, what we are seeing. There is a higher recurrence rate or shorter prostate cancer survival. So these are the germline mutations, what we are seeing. 11.8% of men with metastatic prostate cancer inherit a germline mutations. And when in the localized disease, when we see it is around 4.6%. But these mutations are seen higher as the patient progresses from the localized to the metastatic genes, and the metastatic state, mainly in the CRPC setting, we see a higher incidence of getting these mutations. So this is a single page to summarize at what stage, what all trials are done based on the stage of the patient. So if you see on the active surveillance, what we see, Carter et al. Has told that the variants like the BRCA1, BRCA2 have a hazard ratio of almost like 1.96 of getting these advanced higher risk of in the family history when compared to others. When in the Sundi et al. In 2015, again I mentioned that the African American origin had 3 times higher chance to likely to reclassify the prostate cancer when we have done a biopsy. There is a means progression of the biopsy score is there. Again in the here we don't have anything, but in the locally advanced phase we have the multiple trials which have shown. So multiple trials which have shown that the 3-fold higher risk of nodal disease with the carriers rather than the NOR carriers. So again, in the post-radical radiotherapy arm also, there is a higher risk of disease recurrence. So what I mentioned in the previous slide, they are almost the same thing. If you have these carriers, the incidence of developing aggressive disease is much higher. So that is the reason we should be doing all this testing. Even in the metastatic CRPC setting, you see, we all know about the profound trial, the olaparib, where there is definitely advantage when compared to the non-carriers with the BRCA1, 2, and ATM. The talapro trial with the talazoparib, then we have the rucaparib trial, then again the niraparib trial. So all these trials have shown benefits. Again, but in the docetaxel, we have not shown any significant difference between the carriers and the non-carriers. But again, if you see here in the platinum chemotherapy trials, the BRCA2 carriers have shown better response of the PSA decline when compared to the non-carriers. Again, one more trial on carboplatin has shown similar things. So even in that same thing, again mentioning on the platinum chemotherapy, the same trial has shown more than 50% response in at 12 weeks in patients who have been carriers of BRCA2 compared to the non-carriers. Again, on the screening, when I come back, there are certain trials which are undergoing at UK. There's a barcode 1 trial and the profile 1 trial, where they are doing the genetic profiling in patients with higher chances of prostate cancer by contacting their general practitioners and getting the data of these patients, the high risk groups, and they are trying to do a screening study on them. Similarly, the profile 1 study, again, they are doing a genetic on the high risk group. They are doing a comparison along with the sensitivity and specificity of the PSA. Also, they are trying to study the biological samples of these patients of blood and urine, and the image technologies like the MRI and the new imaging techniques. They are trying to compare and to see what is going to be the disease status on these patients. So what the NCCN says is, again, for all the stages, there is a recommendation to do this genetic testing in all the patient, the molecular profiling, definitely in the metastatic phase. So now what we have started to do is any prostate cancer patient who is metastatic especially. So metastatic, there is definitely a recommendation as of now. We have to do the somatic testing or the germline testing if you feel that the patient carries a high risk group for the same genetic. So the NCCN what is trying to do is trying to risk stratify based on these gene expressions and the biomarkers, and also using the artificial intelligence pathology called as the multimodal artificial intelligence MMAI. So based on that, they are trying to do genetic stratification in this patient to understand how they are going to perform when they are treated. So post-RP patients, if they have this gene study done, what is a DECIFER 22 gene genomic classification. So if it is predictive of a distant metastasis. So if it is positive, yes, then the patient has a higher chances of a distant metastasis. Similarly, for the MCRPC patient, we already know these are the required tests we need to do. Again, for the intermediate risk and the high risk group, if the genomic scoring is less than 0.45, you can make a treatment decision of whether RT or RT with short dose of radiation therapy has to be done. In the high risk group, based on the scoring, you can decide the treatment of the patient. So similarly, in the post RP BCR, based on the genome scoring, whether you have to decide only RT or RT with ADT. So these are all ongoing things. So this is all recommended by NCCN. Again, in the NCCN, if there is a biomarker plus or minus, you have to decide the treatment of the patient. So this will help you decide your treatment planning for the patient, whether you have to be more aggressive or less aggressive based on the genetic profiling. So same thing, the EU also mentioned, EU doesn't have a lot of recommendation, but mainly on the germline testing, patients with multiple family members, a family member who has died, which I mentioned initially, to do genetic testing. Patients who had somatic testing positive, they should be considered for a BRCA testing, also germline testing. Again, for my take-home message, I would say that the genomics into the prostate cancer has a very strong hold now. At all the levels, screening is definitely, then diagnostic and treatment pathway, especially as of now, already there is a full recommendation to go for the metastatic CRPC and the CSPC setting, and offer germline testing to all patients who have family history of prostate cancer, and offer somatic and germline testing for all diagnosed prostate cancer. Things are still ongoing. We'll come to know in the later future, like whether in localized also we should be doing, or we should be using as per case basis. Thank you very much.
Thank you, Dr. Rakesh. So how common are these genetic abnormalities in Indian patients? Can we extrapolate all these to Indian patients, or are we different genetically?
So genetically, we are different, as what I mentioned in the in my initial introduction slides also. What we see in Indian patients, whatever we have done is less than 5%, sir, as of now. Even 5% is more, I will say. It is somewhere between 1 to 2% only what we are seeing as of now. Hardly any patients are showing any somatic or germline positivity as of now.
What are the tests you are doing routinely, sir, in your center? Because it's an advanced center. Are you doing any tests, genetic tests in high-risk patients? What are they, and how much cost it will put to the patient?
It is costing somewhere around 14 to 20,000, sir. Centers, it will vary. So there are multiple laboratories are there. From our hospital also, it is outsourced. For most of the hospitals, it's outsourced. There are some centers like Shivatsa Center, they are doing within the center. So you need some equipments on all those things, and a pathology team needs to be trained for that. So mainly the BRCA2, 1 and the ATM are the main genes, but generally there is a full set of 22 genes are there, or even more than that. I mentioned about 450 genes. They can also be done. So center to center, but 22 genes are more than sufficient as of now to plan your treatment and to stratify your patients.
Thank you. Thank you.
Thank you, sir.
Thank you. We have again
Overshot.
shortage of time is there.
Yes, sir.
I request all the speakers to stick to your time. You're all experts, and you have presented in many webinars. Please stick to your time. That's my sincere request. Otherwise, we will end up at 10 o'clock. So without wasting time, may I request Dr. Srivatsa to talk on active surveillance for low-risk prostate cancer, who, when, and how. Sri, kindly give very good messages to the audience and some tips to even postgraduates. Thank you.
Yeah, many thanks, sir, and to ASU for this wonderful opportunity. I hope my slides are seen.
Yes.
Yeah, great. So we all know that prostate cancer is a very heterogeneous disease, ranging from extremely aggressive prostate cancer to very mild docile prostate cancer, which probably may not require any treatment at all, giving us an opportunity to do what is known as active surveillance, where we monitor patients actively without actually treating them, thereby giving a benefit of avoiding all the potential side effects that can happen with the treatment, and try and see if we can achieve the same or similar kind of lifespan throughout the journey of the patient. So the aim of active surveillance is to avoid or at least delay the potential complications and adverse effects of treatment while maintaining equivalent expectations of cure, and when required, with identification of early signs of progression of disease. So this is the main aim of active surveillance, and the validation for this utility of active surveillance has come from many trials, but notably from this PROTECT trial, which is now read out its 15-year-old follow-up data, which shows that both the clinical progression as well as metastatic disease and eventually death from prostate cancer are more or less similar with active surveillance in comparison to when patients are offered surgery or radiotherapy. There are some differences, but they have found out that they are not statistically significant. However, the authors of PROTECT trial have highlighted certain key conclusions, though they find that active surveillance is a good proposition for patients with very low risk prostate cancer. They say and accept that the current risk stratification methods are unreliable and routine utilization of new tools are needed to better stratify a patient into active surveillance. And they also say that active surveillance can eventually also be utilized for not just low risk, but even patients with intermediate risk prostate cancer. These are again some important aspects that have come up from the PROTECT trial data. One is upgrading, where eventually when a patient got a surgery done, a patient on active surveillance got a surgery done, the pattern of Gleason score that was there actually was different from what was seen on the biopsy. The trial shows that upgradation of the disease in a patient who underwent prostatectomy within 12 months of randomization. That is, if a patient was randomized to active surveillance and for some reason had to undergo radical prostatectomy within the first year of active surveillance, the upgradation risk was more than 32%. This is significantly concerning. Not only was upgrading high, the upstaging was also high, and the upstaging to either PT3 or PT4 happened in close to about 30% of patients. Again, highlighting the fact that patients who are being offered active surveillance should be really carefully selected. So now who should be offered active surveillance? Broadly, these are the parameters that are favorable candidates for active surveillance when their PSA is less than or equal to 10, the PSA density is less than 0.2 at most, Gleason grade of 6 or lesser than 6, only 2 or 3 cores positive of a minimum 10 core biopsy that has been done, and whenever the core is positive, the core length involvement is less than 50% positive, and in a patient who typically has a clinically benign feeling prostate. So these are the potential candidates who could be offered active surveillance. So what are the components of active surveillance? Several trials have looked at several components more or less overlapping, and there is no uniformity as such. However, based on all these parameters, the current guidelines recommend utilization of the grade group, PSA, clinical tumor stage, again mind you it's clinical tumor stage, PSA density, tumor volume, and only a couple of guideline agencies like the EAU and the NICE guidelines have now incorporated utilization of MRI findings and the lifespan into factors that need to be considered for choosing a patient for active surveillance. So again, just to reiterate, these are the top 6 evolving criteria for eligibility. And here you can see that though MRI was not utilized routinely in most of the trials, including PROTECT, it is now becoming one of the most important parameters to decide whether we include a patient into active surveillance or exclude. Coming to the key components in management of a patient subjected to active surveillance, these are the parameters that need to be kept in mind. Age and comorbidities, life expectancy. Typically, active surveillance is offered to patients who are expected to live long, and therefore avoid any treatment-related side effects in these patients. Validation of diagnosis again is very important, meaning to say that we should be really certain of the pathological and the radiological diagnosis of low-risk cancer. Patient education and counseling again is very, very important because patients can tend to become very anxious because it is not easy to say that you have cancer but you don't, we are not going to treat you. So patient education, counseling, and making the patient aligned to this concept of active surveillance is also very important. And lastly, it is important to apply newer tools like MRI, biomarkers, artificial intelligence, and various nomograms into decision making for patients on active surveillance. So how do we do it? This I have adopted. This is a table from the prior trial. So this is very user friendly. So I used it here. This is how we also do it in our center. We do a PSA every once in 3 months continuously. It's an ongoing process. We do a clinical examination with every patient visit, but the trial protocol says that you can do it every once in 6 months. Biopsy is done and patient is put into active surveillance, and a biopsy is mandatorily repeated regardless of the other parameters at the end of 1 year. And if the second biopsy report findings are consistently normal or consistently similar with the first biopsy reports, then a biopsy is repeated at the end of 4 years. So now I would like to discuss more about what's happening in the last 4 or 5 years as what we call as the risk adapted surveillance. Risk adapted surveillance basically has two components. One is the disease risk assessment. The other one is the health status assessment. In disease risk assessment, we are now routinely incorporating the utility of multiparametric MRI to ascertain the actual burden of disease. In some instances, we can also use biomarkers like the PHI, 4K and other tissue markers to make a decision on whether to continue active surveillance or skip active surveillance. Also, patient's health status assessment is very important. So all these parameters have to be kept in mind. So now, if there is a patient on active surveillance and we suspect that the disease has progressed, we need to evaluate for that. So what are these triggers for evaluation? One is change in PSA kinetics and density. Second is change in the digital examination findings. Third is change in precise scores on MRI, which I'm going to elaborate in the next few slides. And then if there is patient apprehension, if the patient is worried that his disease is progressing, then that is also a trigger for patient evaluation. Before we say that the patient has progressed, biopsy is mandatory to, prior to treatment reclassification. And if the patient is very apprehensive about disease progression, it is not fair for us to change over to active treatment, but the patient concern should be addressed by counseling, and then only we should contemplate a change in treatment parameters. I'll just skip this. So coming to the MPMRI, which is actually a game changer for most of the active surveillance patients, it is now considered to be integral to diagnosis and management of prostate cancer. It is useful both for diagnosing and during active surveillance of the patient. The advantages are that it identifies high-risk lesions and it demonstrates out-of-template lesions and facilitates targeted biopsy so that we get the highest possible Gleason score in a patient who has been biopsied. There are several challenges like challenges of interpretation, challenges of availability, so on and so forth, and even targeting the lesion during biopsy. Not everybody will have a facility to target the do a MR guided biopsy. So these are the challenges of MRI. And this is again very important. I wanted to highlight this. So we all now know that MPMRI will report in PIRATES category, PIRATES 1, 2, 3, 4, and 5, like how we do for breast cancer. However, in a patient on active surveillance, it is probably useful to use the precise criteria, which indicates how the lesion has moved from a serial, that is from the time of diagnosis and throughout the journey of evaluation. So based on that, there are 5 precise scores, 1, 2, 3, 4, 5. Up to 3 indicates that the disease is stable or resolving. The moment there is a change in the nature of the lesion, it is categorized as precise 4. And if there is appearance of new lesions between PIRATES 3 and 5, it is called as a precise 5 score. The moment there is a precise 4 or a precise 5 score being reported by radiologists, then it becomes a trigger for re-evaluation. There are, of course, MRI is not 100% accurate. There are several pitfalls and hazards with MRI. And these are the key findings that I am just highlighting. If there are multiple PIRATES 3 lesions, then close to 1/4 of the patients can actually have a high-risk prostate cancer. And there are close to about 20% of patients with PIRATES 4 and 5 lesions who can actually have a negative biopsy. And though serial evaluation with MPMRI can report a normal or a stable finding, altered PSA kinetics have been seen in close to 32% of the patients, which actually had a Gleason upgradation. Last 2-3 slides, novel biomarkers. Again, these are the upcoming tools for active surveillance. 3 types of biomarkers, tissue and urinary. I will not go to the details. Several tissue biomarkers like the Decipher, Polaris, Oncotype DX, which can be utilized, where the presence of certain genetic expression or genetic variants can actually indicate that the patient might have a aggressive prostate cancer, which might eventually progress, and therefore rule out the patient from utilization of active surveillance. Similarly, there are two important blood biomarkers like the PHI and 4K. PHI is available in India, which can be utilized in decision making. And there are several urinary biomarkers, most of which use the PCA3 or the TMPRSS fusion gene evaluation in a voided sample to make a decision on the presence of a clinically aggressive prostate cancer. I will skip this. Finally, is India ready for active surveillance? There is only one paper that I could come across from Dr. Talwani and Gagan Gautam's team, where they looked at 567 records of patients who underwent radical prostatectomy. Then they started looking at those patients who could have otherwise qualified for active surveillance. And what they found out was that only 46 men with low risk prostate cancer were present in their series of 67 patients who underwent prostatectomy, suggesting that a significantly higher proportion of patients in India actually come with intermediate and high risk disease compared to others. And this should act as a warning for all of us to be aware of before contemplating offering active surveillance to our patients. What is the future of active surveillance? MRI plus biomarker-based stratification, MR fused evaluation, AI-guided surveillance, and AI-based programs. To summarize, ideal candidates when selected one can benefit from active surveillance. Risk stratification and risk-based surveillance is the key for selecting an appropriate patient. We have to always remember that the risk of disease progression is real, and we should be aware of this with every follow-up surveillance that we do on a patient. And government tools may aid in supporting active surveillance decision in the near future. Thank you very much.
Thank you, Dr. Sri.
Sir, request the audience to put 1 or 2 questions so that it will be interactive. More
Okay.
than 100 people are there. Actually, we have taken this Zoom. Previously, it was 100 only. 110, 115 it touched. That's why we have taken this Zoom. You can take one question. If you permit one question, sir, can I ask?
Yes, please.
Sir, medico-legal implication, if patient comes...
Meanwhile, can I share it? My presentation.
Gopi, wait 1 minute, please.
Yes, Dr. Gopi.
Just 1 minute, Gopi. Srivatsav, sir, if, for example, 75 years fit patient, if you have gone for active surveillance and he lost follow-up and suddenly comes with advanced disease, what are the medico-legal implications on the surgeon? It can happen in India. That's why I'm asking.
I completely agree, sir. That's why in one of my prior slides, I told you that patient counseling is the key. So one of the critical components of counseling will be to ensure that the patient understands that this evaluation is an ongoing process and disease progression can be a potential risk. And therefore, at some point in time, the patient might have to undergo a treatment. So this has to be discussed in depth and in detail with the patient and the family first up. Only when the patient is aligned,
Sir,
then we can contemplate active surveillance. And
Raghunath,
once
sir.
we have this discussion, it will be recorded, and I don't think once it is appropriately recorded, it could be a medical legal issue.
Yeah. Sir, Raghunath, sir, are you also practicing this biopsy mandatory if you take a re-decision to go for active treatment, especially if it is less than 1 year? Do you go for biopsy again or MPMRI and go ahead with the surgery or whatever your treatment?
It depends on the clinical scenario. I always do MRI. Of course, very few patients of mine are on active surveillance. Very few.
Okay.
So they undergo, if required, biopsy. Depends on the MRI and the PSA values.
Okay.
Sri, I would like to ask you, how many of your patients are on active surveillance, and is it viable in your practice?
Yeah, thank you for the question, sir. I didn't want to include personal data. It is good that it came up. We have currently 27 patients on active surveillance. Because of this topic, I have seen the data. The oldest follow-up that we have is almost close to 5 years now. We have converted 3 patients into radical prostatectomy during the follow-up of active surveillance. I think if we have selected the patients carefully, active surveillance can be really a good tool even in our country. However, ensuring that all these caveats are kept in mind and adopted.
Yeah, thank you, Sri.
I will ask one a primitive question, sir. Don't mind. If any patient diagnosed with 2 PSA as prostate cancer and 10 PSA afterwards, if you treat both with radical prostatectomy, do you think that survival will be changed? There is a possibility that it can. What is the possibility of the survival alteration? Same patient at the level of 2 if you operate, at the level of 10 PSA if you operate, and locally confined, of course.
Sir, it depends again, sir. Like I said, we are not sure. It's just not the PSA. We should actually look at the biology of the disease more in detail with the Gleason score. So there are many patients who have very low PSAs but can have even metastatic disease. We have seen, I think Dr. Raghunath has remember, even at 0.5, 0.8 PSAs, we have seen metastatic disease. But I think the key is the Gleason score. Grade group is the key. If the patient with a 2 PSA has a Gleason score of 3+3, and if the patient with a 10 PSA also has a Gleason score of 3+3, and the MRI findings are consistently normal or similar, I don't think there will be any difference in the outcome.
Dr. Anurag Sahu has asked for low risk cases, can we try focal therapy? In fact, it is the next topic, so we'll go for it. Okay, sir. Over to Raghunath, sir.
Yeah. So we are behind schedule. I request right away Dr. Gopichan to speak on role of focal therapy in organ-confined prostate cancer. Now,
am I audible and my screen is seen?
Yes.
Please go ahead.
Yeah. So thank you very much for giving me this opportunity. I'm Dr. Gopichan. I would like to thank both Dr. Chandra Mohan, Dr. Raghunath, ASU for giving me this opportunity. I'm talking on role of focal therapy in organ-confined prostate cancer, current evidence and future this thing. So the main rationale behind it is that the index lesion, the index lesion is the one which drives the tumor growth and metastatic risk. So this is the rationale behind using the focal therapy. It targets the cancer while sparing the urinary and sexual functions. The targeted tissue is to preserve the neurovascular bundle, bladder neck, external sphincter, and rectum. There are lesser side effects. With the conventional radical prostatectomy and radiation, there are higher rates of associated functional complications, with erectile dysfunction being very high, and urinary incontinence also. The figure, it is between 2 to 72%, various papers. Rectal toxicity, not much, but definitely more with radiation. What are the options that we have as far as the focal therapy is concerned? HIFU, high intensity focused ultrasound, cryotherapy, focal, as the slides come, I will talk about all these things. Focal laser ablation, mainly HIFU, then the TULSA Pro, the transurethral ultrasound ablation, and irreversible electroporation and photodynamic therapy. These are the things that I'll talk much. Let me first of all go into the patient selection for focal therapy. So essentially the disease has to be low to intermediate risk with no extracapsular extension or seminal vesicle invasion, PSA on the lower side less than 10. Tumor location is very important, should be confined to the prostate, away from critical structures like neurovascular bundle, bladder neck, external sphincter, rectum, and the index lesion, the dominant lesion visible on the MRI is a very good case. Confirmatory by targeted biopsy, preferably unilateral, but there are some focal therapies which, even if the dominant lesion is not there, it is useful. Performance status should be fit for the local therapy. Let me first talk about HIFU first. HIFU, the delivery method is transrectal ultrasound. So it is transrectal ultrasound probe which is used. The mechanism being ultrasonic waves is absorbed by the tissue, converted into heat more than 80 degrees, causing coagulative necrosis. The rectal mucosa, the intervening rectal mucosa is protected with the coolant. Ideal prostate anatomy is AP diameter of less than 4 centimeter, no prostatic calcification. Larger glands is to be treated with TURP first. The focal length is also very important. Let me just go through just some picture as the video of focal therapy. The probe is in the rectum, and then this the ultrasonic waves are then with the focal length being less than 4 centimeter, then slowly this is being done. So the probe essentially is in the rectum, and the focal zone, and one by one, this thing is then kind of burned by ultrasonic waves. The multicentric trial of around 5 years outcome of focal therapy in treating clinically significant prostate cancer. The results from this paper is around 625 patients who underwent focal HIFU. 84 patients had intermediate risk or high risk, and median follow-up was around 56. Look at the failure rate. Failure-free survival is very high. The failure rate is very low, around 1 to 10%. Over around 5 years, it's around 12%. The next therapy that I'm going to talk about is cryotherapy, little different from HIFU. The delivery method is organ-based cryoprobes that are placed transparently into the tumor under truss guidance. It is a cooling of the tissue to the temperatures below 30 degrees Celsius, which leads to the cell death. Again, here the rectal mucosa is again protected. The focal therapy results from this very large national cryo-line database, Ward and Johnson performed analysis here of around more than 1,000 patients who have underwent this therapy. They reported a urinary continence rate of 98% and rate of maintenance of spontaneous erection being around 58%. So this is also a very successful therapy, although the cancer rate was little on the higher side. Then photodynamic therapy, intravenous administration of photosensitizing agent activated by light, which is delivered by the optical fibers, again done transperineally. Some agent is first pushed into the prostate, and these are activated by the optical fibers. The activation results in production of reactive oxidative species, which cause direct cellular injury. And here again, the paper by Azori et al. It's an open label phase 3 randomized control trial. Again here, the progression was less than the active surveillance. Most of these focal therapies are in between active surveillance and radical treatment. So again here, if you look at the ED complications and other urinary tract complications, which are very less when you compare with the radical, but little more than active surveillance. The focal laser ablation is another therapy which can be used. It is again requires placement of laser fiber directly into the cancer tissue. This is irreversible extraporation, includes the placement of electron needle probes through the perineum into the ablative target under ultrasound and MRI guidance. Again, Van Del Bos investigated around 63 with low and intermediate risk are treated with this, and the in-field recurrence was very less. I'm not going to talk much about focal brachytherapy, but it is one of the treatment. Now, when you compare between HIFU, photodynamic and irreversible extraporation, most of them are similar. MRI is needed. Most of them are very precise, and the safety and the are under investigations. The long-term results are not there, but most of them have very less side effects. One more very newer therapy which is available is Tulsa Pro. Tulsa Pro is usage of MRI guided transurethral ultrasound ablation with the help of sweeping ultrasound and continuous rotation. Large uniform ablation of the prostate is done. There is active cooling of urethra and rectum which is done, and MRI is needed in planning in this, and it is an MRI guided thing. And again here you can see that urethral probe is passed and plus an MRI endorectal probe, both are used in this, and then an ultrasonic heat is generated onto the prostate, and the treatment completely is under the vision of both the MRI and ultrasound. So here the treatment is much more precise, doesn't take much time, and you can see this is one of the live treatment which you can see here that the heat is being generated all across the prostate gland. So here in this particular method, the whole of prostate can be kind of, a lot of heat wave can come up and it can burn the prostate. This is the thing that happens in the Tulsa. This is one of the paper which is Tulsa Pro ablation. We met Dr. Claus at the SIU also. He was talking a lot about this. The paper is 2016 to 2018, around 115 patients, most of them low, intermediate, and even the high-risk group were also taken. The whole gland ablation was done with urethral cooling, and the primary endpoints was adverse event and PSA reduction, and you can see the result here. It was negative for any malignancy. 1-year core biopsy was around 80% were negative. There's only 16% failure rate. The adverse events were very low. We can look at the urinary continence and functional erection was around 81 to 87%. Even the continence rates you can see is more than 90%. So one of the good focal therapy options that patients have is Tulsa Pro. Many centers in US are doing. This is one of the cases of Tulsa Pro that you can see. Look at the amount of heat that is generated. The cancer cells are either radiosensitive or chemosensitive. Some of them may be radio resistant, or some may be chemo resistant, but most of the cancer cells are heat sensitive, so there is an acute cell kill by the Tulsa Pro. Around 90 degrees is the temperature that is been created in the prostate. Here, look at, these are all the yellow and the red zones are all ones wherein there is around 90 degrees Celsius temperature which has been created. So this is one of the very good options is for focal therapy. Again, I look into the AUA guidelines. Here, there is no robust evidence of efficacy. Therefore, clinicians should inform the localized prostate cancer patient considering HIFU and focal therapy that these treatment options lack robust evidence of efficacy. This is an expert opinion. Another statement in the guidelines is that clinicians should inform the localized prostate cancer patients who are considering HIFU that even though HIFU is approved by FDA for destruction of the prostate tissue, this is the line which is there in the guidelines. This HIFU is approved for destruction of prostate tissue, but it is not approved explicitly for cancer prostate. So there has to be a discretion which is to be taken by the informed consent has to be taken from the patient. The EAU guidelines and the NCCN guidelines both only offer focal therapy with a clinical trial setting or a well-designed prospective cohort study. So it is not there in the option in both these guidelines. But otherwise, you can look at the results of most of these trials. Although they are very, the numbers are small, the follow-up is not great, but the side effect, if you look at it, is really less. So essentially what we have in focal therapy today is one is HIFU and the Tulsa Pro, the Profound Medical's Tulsa Pro, which is going to come up in a very big way. There are many centers in USA which are doing this Tulsa Pro, so they are going to come up in India as well in a big way.
Thank you, Dr. Gopi. We have shortage of time. Without questions, we'll move on to the second one.
Sure.
Dr. Chandru, please pardon me.
Okay.
Yeah. We had to cover two more talks and important talks, and we have one more.
Thank you.
Discussion. Thank you, Dr. Gopi. Dr. Srini, request Dr. Srinivasan Chilikuri to speak on radiotherapy for organ-confined prostate cancer. Again, I request you, be precise. Thank you.
thank you, Dr. Raghunath and ASU for the kind invitation. I hope you're able to see my slides and you're
Yes,
able
yes.
to.
Yes,
Yeah,
yes.
hear me.
We can hear
Perfect.
you. We can see your slides. Please go ahead.
Great, great. So I will cover a little bit of summary of evidence, that is what has been asked, and a little bit about benchmark outcomes of radiation. What are the techniques of radiation which are offered, and some of the promising emerging techniques I will also cover a little bit in the next 8 minutes. And my disclaimer is, because of the want of time, I'll restrict myself to organ confined, and I'll be focusing only on external beam therapy techniques and not brachytherapy. I can take questions if required, and I will not be covering ADT and the sequencing part. We know now that EUA guidelines, ASTRO, as well as SIOG guidelines, and most of the common guidelines internationally use radiation as part of the treatment. So it is one of the, I would say, alternative standard of care for most states of prostate cancer, including intermediate risk and high risk. Of course, low risk, assuming that some of the patients of low risk would be eligible for active surveillance, if not all. So the best evidence comes from the PROTECT trial, where it's a randomized trial, we know, and we have now 15-year data, very little to choose between all these modalities, been covered by previous speakers as well. Although there were certain subtle differences between the profiles of side effects or outcomes between surgery and radiation therapy, largely they were comparable and very little to choose as far as the outcomes are concerned. Now, in high-risk prostate cancer, similarly, there were a series of studies which have compared ADT alone with ADT plus EBRT, which is radiation therapy. And there were a few studies of radiation therapy plus or minus ADT, and all of them have suggested the standard of care, which is radiation plus ADT, either short-term for intermediate risk or long-term for high-risk prostate cancer patients. More contemporary evidence comes from the PACE-A trial. Of course, it was an ambitious trial of surgery versus radiation in mainly intermediate risk prostate cancer patients. A majority of them received contemporary surgery, which is a robotic surgery, contemporary radiation. But having said that, it's still not the best types of treatment, and therefore we see slightly overestimated toxicities. But having said that, the urinary incontinence rate was higher with surgery. The bowel issues were higher with radiation therapy. And the SPCG15, which is more of a locally advanced cancer trial, which is a randomized trial between surgery and radiation, hopefully will answer many further questions in the future. So what are the benchmark outcomes of radiation therapy? What would we tell our patients? What are the outcomes of radiation therapy? This is a trial from the CHIP trial group, which is United Kingdom, and essentially the 10-year outcome with a 12-year median follow-up. 10-year outcome, you can see that with 60 gray radiation, about 80% of them remain event-free in biochemically progression-free at 10 years. Whereas at 10 years, the metastasis-free survival was close to 95%. And there was, again, although it was a non-inferiority study, 60 gray was slightly superior compared to 74 gray. It had borderline clinical significance. And we also have long-term toxicity data that moderate urinary bother was seen in about 10% of patients. Moderate bowel bother is seen in about 7.5% of patients. And requirement of any procedure to alleviate the urinary issues, such as TURP or any urethral procedures, was less than 1%. Similarly, late bowel toxicity, although sigmoidoscopy was required in 10% of patients, the actual need of stricture or a requirement of any major medications was not required in a majority of the patients. You can see less than 1% of patients. The local progression rate also was in a randomized trial or 15-year data, where we see that with high doses, contemporary doses of radiation, the rates of local failure or local progression was noted only in about 4% of patients. Similarly, with modern radiation therapy, what I showed in CHIP trial is not in isolation. Majority of the large randomized trials which have followed up patients for at least 10-year period seem to have about 84-85% 10-year biochemical progression-free survival and 10-year prostate cancer survival of about 95%, even in patients who have high-risk organ-confined prostate cancer patients. Now, can these results be improved? I think yes, by in these high-risk cohort, when we include lymph nodes up to the bifurcation of the iliac vessels, we see, especially in patients who have 80% T3, T4, a median nodal involvement risk of 42%, half of them at least having higher Gleason grade. The POP-RT trial from TMH has shown that the results of biochemical progression-free survival about 95% and metastasis-free survival about 96%. Of course, we will see the 10-year results of this trial as well, essentially showing that these, as previously mentioned, could be improved. In prostate, for urologists, for all, most of you already know that because of unique radiobiology of the prostate, less is more, and therefore a less number of fractions is actually good enough, or in fact even better, because of better convenience, cost, and also makes sense radiobiologically. Now, there was a trial which was called a PACE-B trial, again in intermediate risk population, where 5 fractions of alternate day 5 fractions of 7.25 gray per fraction was compared to 8 weeks standard radiation versus or 4 weeks of radiation therapy. And they showed that extreme hypofractionation, which is 5 fraction, was non-inferior to the 8 weeks or the 4 weeks of radiation in terms of all possible disease outcomes. The toxicity, although was slightly higher temporarily in patients who received shorter fractionation, it seemed to not matter when it comes to long-term late toxicities at 2 years. There was very little to choose between these different fractionation, essentially saying that a majority of organ-confined patients can be treated with 5 fraction schedule. Now, can this be extrapolated to patients who have high-risk features, who have a higher propensity for nodal involvement and therefore need to be treated lymph nodes as well? This question is still unanswered. And again, Dr. Vedang Murthy from TMH has embarked upon a randomized trial, which will compare moderate hypofractionation with extreme hypofractionation in high-risk cohort, which will include patients who will require lymph nodal irradiation. And our hospital also is participating, and we are almost close to accrual of this 500 patient randomized trial. Now, what is a technique which needs to be used? And just to inform all the surgeons that the bare minimum technique is image-guided radiation therapy. I think if any technique which is less than this should not be ideally used for prostate cancer, because now there is level 1 evidence to suggest that when you use image guidance, the results are better. Now, what image guidance to use, whether fiducial or a CBCT or an image guide, MR guidance, which we still don't know, but there is a small Mirage trial, which is a phase 2 randomized trial, which showed that with MR guidance, you can reduce the margins and therefore reduce the toxicities. And this was shown in a randomized trial fashion. This was an early results, but at least very, very promising that if you reduce the margins, the toxicities seem to be less. Now, there are other techniques such as spacer insertion between rectum and prostate, which again, a randomized trial has shown that could lead to reduced amount of rectal toxicity. Now, there is a unique form of dose escalation which has been tested in a phase 3 randomized trial. So instead of irradiating the entire gland and increasing the dose to the entire gland, only the dominant intraprostatic lesion focally has been escalated to a higher dose, and rest of the gland would receive a standard dose of radiation. And this trial showed that when you escalate the doses, the DFS, the biochemical disease-free survival, was significantly better, although there was no difference in MFS and OS, and there was no difference in toxicity. So this focal dose escalation did not result in increased toxicities, another very promising approach which can be considered for future. Similarly, other techniques such as proton also have been used. You can see that you don't have to be a radiation oncologist to appreciate the difference between photons and protons. This is the best possible IMRT technique we have today compared to protons. We can see now there are long-term data, even including 10-year data, which shows that protons seem to be extremely efficient in terms of disease outcomes and low rates of toxicity. And we have shown in our 150 patients with 6-year experience that the toxicity have been very low. And we have shown that high-risk patients who require lymph nodal irradiation, 2/3 of them could benefit with protons. Of course, a randomized trial needs to address this once and for all. but the reduction in toxicities, 16%, and GU toxicities of 12% were also noteworthy. To summarize, apart from surgery, radiation therapy is another standard of care along with surgery in organ-confined prostate cancers. Benchmark outcomes I have discussed. Extreme hypofractionation can be used, that is 5 fractions, can be used for most patients of organ-confined prostate cancer patients. Can it be used for high risk? It is still being evaluated. The minimum dose should be 74 gray, 80 gray is preferable. IGRT is the minimum standard, gold standard with 5 millimeter, 3 millimeter posterior margin. MR guidance if it can enable smaller margins. Rectal space that is preferable. And there are certain emerging techniques which appear promising. Thank you very much.
Thank you, Dr. Srini. So wonderful talk on radiotherapy. If any questions are there, Dr. Chandru? Thank you, Dr. Srini. Please wait. We may expect some questions. We'll let you know. So we will move on to the next topic by Professor Nikhil Vasudev. He's in a tumor board meeting. He is chairing the tumor board meeting. He has shared a video with Dr. Chandru. Dr. Chandru is going to share the video. Yeah.
So thank you for asking Professor Nikhil Vasudev. He is a well-known person, and Raghunath has connected to me. For the PGs and the juniors, it will be very important to listen this video. I am sharing the video now. It is with voice. Is it visible, sir?
No, it is not visible.
Yeah. Just 1 second. I am optimizing and sharing. It's a big file, then meanwhile, he is opening, and just 1 second.
Meanwhile, Dr. Raghu, you are doing HIFU in your center?
Is it visible?
Yeah,
Well,
it is
thank
visible.
you
Thank
very
you.
much for the invitation to speak on the state-of-the-art lecture at your meeting on robotic prostatectomy, in which I'm about to showcase to you some of the very latest research ongoing to make it more precise, and how we are using AI in our center and nationally in the UK in collaborations with other centers
Is it voice okay?
to help patients. So I hope to showcase to you the very latest taking place with robotic prostatectomy.
Yes, Dr. Chandra Mohan.
So
Thank
I'm
you,
very
thank you,
grateful
Gopi.
for the invitation to the meeting, to Raghunath, who's a dear friend of mine, and obviously many congratulations to his team at the HCG for crossing such a massive milestone of doing so many robotic cases in India. So robotic uro-oncology surgery 1250 is a massive landmark. So congratulations to him and his team. And obviously I'd met Raghunath in Delhi at home, and plus I do tend to meet him at a few meetings and really enjoy our academic interaction. So thank you very much for the invitation. The main onus of robotic prostatectomy in the UK is largely down to quite a lot of demand taking place. So prostate cancer is on the rise at a very significant level, and what we tend to see is the implementation of something called the fast diagnostic standard in the UK, in which patients, when they're seen in the primary care with an elevated PSA level, are sort of sent across, and we have to treat them in a very fixed time frame. And this time frame now, which stands at 31 days from diagnosis to a decision to treat, is being shrunk down to 28 days. And it's now envisaged that this will even drop further to 21 days. So the whole thing is shrinking, especially at the beginning of the pathway, because lots of patients with an elevated PSA tend to have an MRI, and then we do some targeted biopsies in them. as against systematic biopsies. The type of biopsies that we tend to do, so this is a recent paper of mine published in Urologic Oncology, a systematic review led by Kim Chan, my specialist registrar, international collaboration with Jeremy Theo, Prof. Das Gupta, who I do a lot of AI work with. But essentially, we're trying to evaluate and see what's going on. But if you focus down here, this is what we tend to use. This is a local anesthetic precision point biopsy that's done in the outpatient clinic. And certainly patients will have a multiparametric MRI. We have stopped doing truss biopsies completely. And we also trying to integrate a lot of PSMA, CT, and PET to diagnose prostate cancer and clinically significant prostate cancer. In the UK, certainly bone scans have been wiped by SPECT-CT to identify oligometastatic disease. Now, some of the data which has been run in my lab projects, which I'll showcase to you, because this lecture is not only about now, but what the future holds with robotic prostatectomy. So this is a whole mount, and I've got 2 trials for which I'm sort of lead investigator to basically evaluate preoperative planning for robotic prostatectomy.
Voice is not audible, Dr. Chandra Mohan.
We may see
Voice is slightly low.
So we have a fairly big team at the Lister. So we have 4 robotic surgeons. Andrew Brody, his new colleague, he does up a track. Jim Nadsett, a senior colleague. This is Ross Warner, who's just sort of got a job in Oxford. He's our Royal College of Surgeons of England fellow. I think, Raghunath also has an HCG Royal College of Surgeons Fellowship.
Chandru, can you increase the volume in your system?
Sir, I'm trying to increase, but it is the maximum.
About 500 600 robot prostates a year. That's the sort of number we tend to hit in our organization. But we've got quite a lot of stuff happening in the background. So we have a dedicated uropathologist. We have biomedical scientists for our neurostate program. We do a lot of research, and I'll show you what we're doing to improve out. Now, all the data from prostatectomies goes on to something called the NPCA, which is the National Prostate Cancer Audit, in which data quality is important. So your individual unit outcomes, not individual surgeon, but individual unit outcomes will be reflected as to whether you're over-treating group grade 1 or 2, Gleason 6 or Gleason 3 plus 4 equals to disease, what your margin status is.
Chandramohan, your computer is muted, then it won't play the video.
True. Even your system bandwidth should be high.
Its computer is muted. How will it play that video?
Chandru, can you please sort out that? Chandra Mohan?
Nerve spare, whether it's extra, intrafascial dissection, it really makes a difference. And I was in Mount Sinai last week in New York as invited faculty, where I presented some of this data at the 6th meeting with Professor Ash Tiwari. And I think Professor Tiwari really leads the way with nerve spare planning. AI is very much here to stay.
Yes.
Chandru, we can't see the video.
Yeah.
Can I suggest something? Because it is a video, we can always have it uploaded as a part of the overall program.
Yeah, we will try for 2 minutes. Otherwise, we will go to the next session, please.
Because anyway, it's a video, so we can always have it as a part of the program. And when we upload this to the YouTube.
Yeah. Just 2 minutes, Sanjay. Okay. Leave it. It is getting paused. Sorry for that. So we'll go to the next topic. That is case-based discussion, 30 minutes. Raghunath, I will take 1 minute again for the announcement of the membership as well as the next webinar. After that, Sanjay, just bear with me 2 minutes. Can you share?
Please. Yeah, please go ahead.
Because this, we have to, yeah, no problem. So for ASU membership, dear friends, because this is a official webinar and it will be YouTube link will be there. For those who have confusion about the membership, permanent member, past history of paying the payment, or you have not converted from PG to this thing, if you have done PG from other area, whatever may be the doubt, the bare minimum I can offer is call this number, the work will get it done. 9032 592742. 9032 592742. It is my duty as Secretary Honorary of ASU to make as many members as possible, more so permanent members. This is my request. Call this number, you will be guided. Even if the other zone members want to become associate member, you can become. We are all associate members of all the zones of India. You will get the communications. Our second thing is we will over to Sanjai Addla later on. You already put it? No? We'll announce later. Okay? Yeah. Dr. Sanjay, who is a senior uro-oncologist, as I mentioned, he is my MBBS classmate, very knowledgeable person. He will conduct the case-based discussion for 30 minutes. Sanjay, more than 85 members are there. Initially, it has gone up to 105. So still good number for a webinar of the present generation. I hope more members will add and get benefited. Thank you. Over to you, Sanjay, please.
Thank you very much, Raghu and Chandra Mohan, for giving me this opportunity. So let's try to go through.
Louder.
I've got an excellent panel. Couldn't have asked for a better panel from South India. So expect to be grilled a bit, Ginil. So I haven't.
Like that.
Sorry?
Yeah. Okay.
Yeah. So I haven't put anybody's names beside any questions, but as we'll go through, we'll learn together. Okay. So everyone is there. Ginil is there. Raghunath is there. Sivaraman is there. Santosh is not there because he's in the USI Council. Ragavan is there and VC Mohan is there. Okay. So we'll go through. Fine. I don't have any disclosures to go through. I'm going to ask probably the most eminent person practicing in private, two of them. SK Raghunath, do you think we should screen? If so, what type of screening in India?
Screening is required, yes. Probably opportunistic screening is possible at all the hospitals. I'm not sure about the population-based screening. Probably it's required.
So you currently think that opportunistic screening, i.e. patients who come for a clinic for consultation regarding lower inner tract symptoms should be screened?
Yes.
Okay. Anand, do you think the cancer that we pick up in patients who come with clinical symptoms, is it any different to the cancer that you would pick up, let's say in population-based screening? Is it any different? And I'm talking of patients who did not have symptoms of prostate cancer. They came to a lower inner tract symptoms clinic.
Yeah, so my take on that is I agree with Raghunath in terms of opportunistic screening, but I generally feel that once they come in with symptoms, there's a potential for them to be much more advanced. So if you don't bring in some sort of picture.
Anand, there is a problem with your communication. What I'm able to hear. Okay. So what Ginil, what is your normal PSA values?
Normal in the sense in general population or
General population.
Patient who is
patients who come to you for your clinic appointment.
Yeah, because my practice is almost entire thing is in the oncology side now. But in the past, when I was seeing a lot of patients used to have fluctuating PSA in our country, like majority will be less. But
patient has had 2 or 3 PSAs, okay, and you take the lowest value. Do you follow these numbers? 2.5, 3.5, 4.5, 6.5?
At present, if the patient is age specific, I go ahead. Like if it is a 50-year-old, I'll just give importance to less than 4 itself, like 3 to 3.5, I'll take give importance. Otherwise, if it is more than 60, 4 will be my cutoff.
Okay, so more than 60, 4 will be your cutoff. And if it is 50 to 60?
Yeah, 3.5, I'll just be careful.
So this is what we have always used since 1993 when this paper was published, 2.5, 3.5, 4.5 and 6.5, which has been the age-specific PSA. But it was a small study based on around 471 people. And since then, we have had this one. The reason why I was emphasizing was this. So if you look at that, for the age-specific PSA that we knew before, from 41 to 50, it was 2.5. But in India, it seems to be 1.7. And the numbers are huge. We had 22,000 people in it. And these were asymptomatic men who came to the master health checkup. So the PSA under 60, our PSA values seem to be lower. So if you remember that when 51 to 60, it was 3.5. So our PSA values are lower in under 60. But the moment you go above 60, it was 4.5 and 6.5. Once you grow above 60, our PSA values are higher than what we have been used to. And the numbers are big enough for us to be confident that these are true representative PSAs of India. Yes. So 1 point, under 60, our PSA values are lower, which is what Ginil was alluding to. And above 60, our PSA values are higher. So we need to concentrate a bit more on investigation of patients who are younger because our PSA values are lower, and probably less or a bit more lenient with respect to investigating above 60. Raghu, any comments on that?
I agree, Sanjay. That has been our observation as well.
Okay, that's good. So PSA screening, we think that all the patients who come, the reason
one more point, Sanjay.
Yeah.
If there is a high possibility of, because we were having the study from the PSM, the biopsy, we were just analyzing our data. So what we found is actually less than 10 PSA. And the number of high-risk patients in less than 10 PSA is quite higher than the Western population.
Yes, in a way, I think we have got more aggressive disease. That's one. As in, we were looking at the partial nephrectomy data as well. For the small enhancing renal masses, our malignancy rate is 90% compared to 80%, which we have been quoting. So unless we have,
so there is a general practice that less than 10 PSA we can wait. Actually, our number of picking up high-grade tumor in this category is higher than the West.
Okay. Good. So this one is a patient. I'm going to ask each of you a number. 64-year-old who comes to your clinic, DRE is NAD, and he says, what is the risk that I might have a cancer? Ginil, for PSA of 1, what do you think overall? If I took his prostate out, what is the chance I will find a cancer? Expecting that he's a Caucasian. I don't know what is the value in India. PSA of 1. Ginil? Give me any number.
Unmute Ginil.
Yeah. The ESRT trial, the chance of hitting a prostate cancer in less than PSA is almost negligible. And they say that even a rectal examination can be avoided. So it will be less than probably less than 10%, 5 to 10%.
5 to 10%. PSA of 4, Raghunath?
Yeah, I would say around 10 to 15%. Whether it's significant or not, we have to decide.
That's a different overall
yes.
risk of cancer. Okay.
Yes.
So in other words, you are saying there is no lower PSA value wherein you say you do not have a cancer. Am I right in saying that?
Yes.
Okay. Anant, we agree with that?
Yeah.
Okay. Expecting that you don't do transperineal biopsy. If you do transperineal biopsy, this PSA 20 guy will 100% have a prostate cancer. Yes. If you are doing a trust biopsy, what is the risk that you will show cancer in his prostate?
I mean, this is a moot point. We never do the biopsies without MRI now. And if the MRI doesn't show a lesion, we wouldn't do it. So just by with the PSA alone, we shouldn't go ahead and even consider this.
Okay.
If the PSA
you just said something. I'll just try to. You said that a PSA of 20, if the MRI is negative and repeat PSA is again 20, you would not do a biopsy?
So I would, definitely do a biopsy. If the MRI is negative, there's a 15% chance that they may still harbor malignancy. So biopsies would be indicated if the PSA is persistently elevated and they don't have prostatitis features.
Okay. I had a slide to indicate that currently there are 2 indications for doing a biopsy. One is an MPMRI PIRAD 4 of 5 or a PSA density of more than 0.15. Either of them seem to be pointing towards cancer. And when both of them are there, definitely the risk of cancer and significant cancer is higher. Agree with that, Anand?
Yes.
So though MRI might be negative in him, PSA density would be higher in him because of the PSA of 20. Okay. So this is
the way to look at it is if the MRI shows a PIRADS 1 or 2 and the PSA density is above 0.15, you will still do a biopsy.
Yes. That's what, even if I was following the guideline, that's what they have said. So the risk of cancer doesn't seem to become 0 even when the PSA is between 0 and 0.5. This is for the PCPT trial, prostate cancer prevention trial, wherein before entering into the trial, every patient had, irrespective of the PSA, they had prostate biopsy and they were shocked to find these are the numbers of cancer. And if you look at it, the risk of prostate cancer with Gleason score rises with the PSA rising, but there is presence of cancer. So if a patient asks you a question, PSA is 2, what is the risk of cancer? We can't say 0. There is some. It's a different question when they say risk of significant prostate cancer. And answering the question from what Ginil has mentioned, overall risk of cancer in prostate biopsies for India currently is 45. And that PSA of 4 to 10 seems to be around 22%. In this one, as Ginil was mentioning, they are finding higher risk cancer, but we await that publication before we make any comment on it. Okay. Raghavan, do you think 45% is high? The denominator is very big, 850. So we have to say this is what is the current standard. Is 45 trust guided biopsies pickup rate is high or acceptable, and you see similar things in your practice?
We see very similar thing in our practice as well, Sanjay. Obviously, it's a full cohort that they mentioned. If you break it down into different PSA segments, it might change a bit, but overall pickup rate.
You see the different segments. PSA less than 4 is 13. PSA is 22.
We are observing very similar. We are observing very similar picture.
Okay, thank you. So this patient. Okay, 3 of them. I'm just going to go back to.
Sanjay, there is a very, very good point. Even after more than PSA of more than 20, almost 30% of the biopsies were negative.
Super. Yes. The opposite of it. Whatever the PSA, it doesn't mean that they definitely have a cancer. You should not clinically treat them with, especially in India, with orchidectomy. PSA is 30. Most probably has got a cancer. No, it is never 100%. So you should not do irreversible treatments for this patient. Thank you.
Even PSA 100, we have seen coming down to less than 4.
Yes.
So infection related PSA raise is very important. This is very important point. There is no question without biopsy doing any treatment.
So both sides.
emphasize that MRI has to be done before you do a biopsy.
Yes,
Yeah.
yes.
I was going too much into the diagnostic one. That's why I had to pick out the MRI scan, Anand. Sorry. Yeah, because I wasn't discussing anything about the treatment if I had any slides on the MRI. So apologies, but I just wanted to cover that part to say that our PSS are different to Caucasian one. Okay, so this one, who would be, I'm just going to, Ginil, anybody in this cohort, A to F, whom you think is good enough active surveillance? Pick one.
The patient with 42, since the PSA is less than 9, even though I'll be very skeptical that there can be a high grade, that patient probably I may go for active surveillance, so that if there is any signs of, since he is recently married, let him enjoy for some time.
Okay,
so
you want to offer active surveillance to B?
To
B.
Then old patient
50.
Yeah, 50. Again, the 10 by 35 is a bit higher range. In Indian patient, 50. This patient I will go for active surveillance, but I'll be very strongly requesting the patient that they should follow up regularly.
Okay. Raghu, patient number C, won't you give him active surveillance?
Yeah, we can. Why? What's wrong in giving active surveillance, even though he'll be a candidate for watchful waiting?
Okay. Raghunath, who is a definitive patient that you say he should have active treatment? Who are the patients?
Definitely, the E would definitely require treatment. 4+3 and 7 out of 12 cores were positive, and if he has IPSS of 10, definitely requires treatment. And D, probably D also, 10 out of 12 cores were positive.
Okay, Anand,
yes.
This F patient, is he an appropriate candidate for watchful wait?
Yeah, I agree. So A, B, and C, watchful waiting, D, any active treatment, F is again watchful waiting. I'm sorry, A, B, and C, active surveillance, D and D, active treatment, F is watchful waiting.
Okay, the closest to person to offer HIFU in this one. Whom would you offer HIFU? Anand. You're not convinced, or you and anybody, whoever should be going on active surveillance can go for HIFU, or D and E can go for HIFU?
No, I'm still not convinced about HIFU. Are you?
Okay. No, I'm not.
E is definitely not. It's 3-3A and 4+3 disease.
Okay, Raghu, you have a HIFU setup, TULSA setup at your place tomorrow. Who in this one would be appropriate candidates for that?
Very interesting question. Candidate C.
Okay, so it's somebody who doesn't need treatment, but you want to give treatment for his
yes,
IPS.
to satisfy his own mind and my mind.
Okay.
And D as well, maybe.
Okay, he's intermediate risk. PSA is intermediate.
The Tulsa guys are saying they even treated high.
Okay.
Lawrence Klotz apparently says he has treated high as well.
But
these are the
guys.
Ragavan, number C is 18 out of 35 IPSS. Would you give him
Given the limited time, let the PGs be also understood. This slide is complex. We are going into the large discussion on that. Make it one point and discuss. A lot of audience are there. They are disappearing. So keep in mind, the message should be given. It's not only seven points on one slide and discuss. People will get confused. One by one, you discuss each point and ask them so that conclusion can come. Please.
Okay.
So and Sanjay can also explain why.
Yeah, that's what I was trying to lead on to this one. So we tend to use for low risk, intermediate risk, and high risk, these three things. So this is PSA less than 10 and, yes, Gleason 7 or less and clinically T2A or less. So it has to be all for them to be in the low risk. So these are the patients we can put them in active surveillance. So we had patients who were on active who were fitting into that one in the previous slide. The reason why I didn't give this before was so that people can think about it. The intermediate is, we don't know whether they are high risk or low risk, similar to the bladder cancer intermediate risk. Who is the intermediate? Who doesn't fall into the high risk, who doesn't fall into the low risk. So let's look at what high risk is. PSA more than 20 or Gleason 7 more than 7 or T2C. So any single feature, they will be going into high risk. And if you look at the intermediate, the PSA is between 10 to 20 or Gleason 7. So this was less than 7, this is more than 7, this is 7. And then the middle one, T2B. Okay. So what you end up when you do operate on this intermediate risk is 50% will end up into high risk pathologically, 50% will end up into low risk at the end of once you have done a radical prostatectomy. So what you need to remember is low risk and high risk, the ones that fall in the middle. If you look at the NCCN one, it divides this into intermediate low risk and intermediate high risk as well. But for simplicity's sake, this is derived from the DMECO, easier to understand, PSA, Gleason, and clinical staging. And this is clinical staging. Though we are not supposed to use the MRI scan, we do end up using the MRI scan for the clinical staging. But when this was defined, it was a finger that was giving this T2A, B, or C. Anything else to add there, Raghu?
No, perfect. Good summary.
So this patient, PSA 60-year-old, neither here nor there, PSA 12, neither here nor there, T2A, Gleason 3+4. Okay. Active surveillance. So this patient, we have already had talks on active surveillance, radical prostatectomy, radiotherapy, and watchful wait. Okay. I'm going to put Anant in this. If this patient wants watchful wait, Anant. Okay. What are you worried about? Him dying of his cancer, him having metastasis, or what are you worried about?
Yeah, but so when you talk about watchful waiting, it means that you don't want to cure him. You want to wait and then treat him symptomatically. Yes.
Yes.
And he's a 60-year-old guy. How long are you going to treat him like that? He is a definite candidate for a curative treatment or maybe potentially active surveillance. I wouldn't even consider this gentleman as active surveillance.
I agree with that. What I'm trying to say,
material.
No, what I'm trying to say is that if the patient says that I do not want any treatment, if you need to tell him the numbers, do you think he's going to die of his cancer, or do you think he's going to have metastatic disease that is going to affect his quality of life?
So
what are you worried about more?
At that point in time, we need to follow him up for a period of time to give him that answer more accurately. Okay. What is PSA velocity? How is things improving? What about his DRE? And what about symptom score? All these things we need to get over a period of at least 6 months before we give an accurate answer.
Okay. Ginil, he wants to go down the line of active.
Actually, PROTECT trial showed that at 10 years, the chance of metastasis is around 25%. If you are having an active surveillance compared to less than around close to 10% if you are doing active treatment. So that will be, so he will be benefited. Yeah, so he will be benefited by having an active treatment.
That's one. But he says that, okay, I want to initially just go on active surveillance. What is the chance I will end up needing radical treatment by 5 years? In that there is a progression. Sorry?
The chance is very high in this patient because he is intermediate with 2 factors, more than 10 PSA and having 3+4.
Okay. Raghavan, you're convinced with Srinivas Chilkuri's talk and you refer him for radical radiotherapy. What would be your fraction? What is considered a standard nowadays for radiotherapy? If you just tell in one sentence what Srini told us.
It's about 74 gray, delivered in about 20 fractions. So about 2.5 gray per fraction, 5 days a week, about 4.5 weeks of therapy. That's the standard of care at this point of time. Along with a boost to the dominant node.
Okay, good. So I just thought for PGs, what Anant was trying to differentiate it into active surveillance and watchful wait. I was waiting to see whether Srivatsa would include this, but he didn't include. That's the reason I've added this. So there is a basic conceptual difference between active surveillance and watchful wait. Active surveillance, we are trying to see whether this patient needs, whether the cancer demands treatment or not. palliative, you're not trying to prevent side effects of the treatment. So the overall intention is to palliate. So watchful wait, you're not going to do much. You just wait until they develop metastasis and then intervene. Whereas active surveillance, you are delaying the active treatment so that it doesn't cause him any harm, but you still get a cure. So it is much more regimented. This is make it up as you go along. Okay, so that's the difference between watchful wait. Probably the most important one is curative and palliative. Everything else will. The moment you say that the intent is curative, all the follow-up and everything will be much more intensive. Okay, so the watchful wait, these are the numbers. I was staggered by these. Each time you read the Bill Axelson paper, it always surprises you. So this one, Raghu, do you want to just give me some one sentence out of that PC, so not the SBG4 trial? What was one sentence outcome from that?
Longer you wait, the surgical arm patients will do better.
Okay.
The immediate difference is not much, but as the patients live for longer, the joy of surgery is felt.
Okay.
So that's the only take-home message there.
Or the other way is that you need to ensure that the patient will live long enough.
Yeah, the surgery as an option should be given for patients only if you believe that they are going to live for 15 plus years. Else, you are not, the joy of what they have to go through will not be there.
Okay. So this one was the Anna Bill Axelson paper, which any PG, if they have to ever read about, this was the first groundbreaking one that came up right from the time we started our training. So this is quite an interesting one. 695 patients. If you look at the time period, this is even before you were born, 1989 to 1999. And if you look at the numbers, PSA was less than 50, age was less than 75. So there was a radical prostatectomy on and watchful wait on. Watchful wait was they didn't get anything, only hormone treatment if there was a metastasis. So this was all the treatment versus almost no treatment. And when you see the numbers, the overall, the radical prostatectomy makes a difference, but more so in younger people. So if you look at this blue is death from cancer. At 18 years, death from cancer in under 65 is prevented when you do radical prostatectomy, and watchful wait under 65, more people die of prostate cancer. So the first take-home message from this paper was, if they are under 65 at the time of diagnosis, do consider radical prostatectomy. That's where the number of 65 comes from. The older they become, there is a difference, but not that very good. And then coming to this, the low risk, intermediate risk, and high risk. High risk, again, if you see, this was the radical prostatectomy on, this was there isn't that huge a difference. No, this was a metastasis one. So this was development of metastasis. Again, because I was asking Anant, what are we trying to prevent? We are trying to prevent death and we are trying to prevent metastasis. Again, goes back to the same. Under 65, you prevent metastasis by doing radical prostatectomy. Under 65, more people will have metastasis if they go down the line of watchful wait. Not that significant difference when they are above 65. Okay. So these were the numbers. Okay. What I was trying to ask Raghavan about it. So at the end of 15 years, the difference between watchful wait and radical prostatectomy is of the order of 5 to 6%. Yeah. I'll say the same thing again. At the end of 15 years, the difference between radical prostatectomy and watchful wait is 5 years. Overall mortality, that is all encompassing mortality, is the difference is 11%. Metastasis progression is 12%. Okay. So those numbers are 5, 11, probably 11 overall mortality is not important, but 5 and 12. So 12% risk of mortality, 12% risk of metastasis is reduced by surgery compared to watchful wait. Okay.
Sanjay.
Yeah.
Many postgraduates are there, and even practicing young urologists are there. Probably after every slide, you can give conclusions for them.
That's
what
why
are the take-home messages in a simplistic way? Okay.
The take-home messages in this one was that we think radical prostatectomy makes a huge difference. It doesn't make a huge difference. That is the take-home message from SPCG4, and that was 5% difference at 15 years. However, things have moved on. The reason why I pointed to those numbers were, this was almost like pre-PSA era. So this was 1989 when PSA started. So it is a very old study, but it gives you some hint of saying that operating on everybody is not appropriate. Okay.
Yes. Earlier they used to, notice, report less than 65 or less than 70 years. Now that age has gone. What is the life expectancy? What is your take on that? Like, for example, 70 or 75-year-old gentleman with an intermediate risk or high risk disease with more than 15 years or 20 years of survival.
Yeah. Raghu, it wasn't a comparison between active. I just wanted to give a take-home message from that to say that watchful wait is an appropriate option, in that we don't kill everybody by doing it.
Right, Sanjay.
Yeah.
Please go ahead. Yeah.
It's just that because in India we are very, I'm not talking of you as for the juniors. I said watchful wait does need to be considered. That's it. I'm not talking of any specific patient. We should just not rule it out and treating every 89-year-old PSA of 6 has an orchidectomy done. Yes, that's what I was trying to say. Just because we can treat doesn't mean that we need to treat. Those were the differences in patients who had radical prostatectomy versus nothing. Almost the reason why I'm saying nothing is they had an orchidectomy or LHRH agonist when they metastasize. Okay, this one was a PROTECT study. So again, it has already been gone through. So I'm just going to come to this, which is what whenever a patient chooses active surveillance, the numbers that we tend to say. So what percentage of active monitoring group end up needing radical treatment? So these are the patients who undergo radical treatment. And I tend to remember it around as 40% at 5 years. Yeah. So what percentage of active surveillance patients in a heavily screened, these were all very, if you look at the numbers wise, all of them were PSA less than 10. Around 76% of the patients were T1C. So these are low risk prostate cancer patients. But even in those low risk prostate cancer patients who are monitored on a daily basis, the risk of needing radical treatment at 5 years is 40%. Okay. Anything to add, Ginil? Sorry, Ginil. Okay. Raghu, can you what are the pros and cons of showing this slide? In that at 10 years and at 15 years, the prostate cancer survival is same between the active monitoring, prostatectomy and radiotherapy.
What the take-home message for the postgraduates is that if you take overall survival as a single parameter, anything that you do, the patients will live. So as just a simple thing, whatever you do, the patients will be fine at 10 and 15 years for early low-risk prostate cancer. That's the only take-home message I will say.
Sanjay, one more point is actually in this PROTECT trial, majority of the patients were of low risk.
Very low risk, not even low.
Very low risk.
Yeah, yes. Very low risk. And only a few patients had an intermediate, and none of the patients, almost none had a high risk. So this is applicable only for a low
screen
risk
detected low risk
patient. Yeah.
Yes, screen detected low risk. Yeah. So for low risk, what I'm trying to get a message across is an 80-year-old just diagnosed with prostate cancer doesn't need to be always treated. That's the one message. And second is
especially not with orchidectomy.
This is only applicable in low risk screen detected prostate cancer. These are the numbers. Okay. So there is a 40% chance of needing treatment at 5 years. Second, cancer specific survival at 15 years. In screen detected PSA less than 10, with 80% of them being T1C, the cancer survival seems to be the same. Okay. And
as Raghavan rightly told, orchidectomy have got more mortality probably if he is living longer than the cancer.
Cancer. Okay, so I'm just going to ask a few questions of the last 5 minutes. So this is from the advanced prostate cancer group. Yeah. So this one, Raghunath, a majority of the patients with localized prostate cancer, clinically T2, N0, M0, I subgrade Gleason scores 3, clear evidence of T3 on MRI. Which one would you take before you recommend treatment? Would you take the clinical one or would you take the MRI one?
I would take MRI one more than clinical one. Of course, I will consider in certain cases, but I will go with more with MRI. The sensitivity of MRI is more compared to our digital rectal examination.
So you're in line with all the APCC specialists. 96% of them said my finger is inferior to the MRI scan. So this one, which is what we see on a regular basis, Anand, in a majority of these are localized prostate cancer, one PSMA positive bone lesion without a correlate on the CT component. What do you recommend as the next investigation and how would you treat him as? MRI you have done probably, MRI is negative. What would you treat him as?
We don't have anything regarding the Gleason score and so on, or PSA levels and so on.
Yeah, everything is on the borderline. If PSA is around 12, yeah, Gleason 3+4, 3 out of 12 course. So it's neither here nor there.
I think then we need to qualify this PSMA positivity with, does it correlate with an MRI at that level to see whether there's anything that tells us that it's malignancy or not.
If it doesn't correlate, you will treat it as just as a misnomer. You have picked it up and then treat him.
Yes, I would treat him like it's not a malignant.
Okay. Which one is a worry? High risk, as I was saying before, could be elevated PSA, could be T2C or Gleason 8 to 10.
I would value the Gleasons at this level.
Gleason is the most aggressive one. And again, I'm going back to Ginil's paper, wherein they have looked
Sanjay,
at...
one small submission, if you don't mind. Raghunath is Dr. Santosh Kumar is there on panel.
But
he's there, but he's with the USI Council meeting.
He was leaving at 8 o'clock.
Yeah, he is there on the screen. So just to remind you, no problem.
Okay.
Please go ahead.
No, he messaged me. That's the reason I wasn't directing any question. Okay. So,
okay, no problem.
So this is from Ginil's team, wherein they have looked at, that's what I was highlighting. A PSA of more than 20 is high risk, or Gleason more than 7 is high risk, or clinically T3A or more is high risk. But when you have 1 factor, 2 factor, or 3 factors, does tend to matter. Okay. I'm not going to go into this one. Okay. This one again was asked for a high risk prostate cancer in majority of the high risk localized non-metastatic on PSMA PET. Okay. Ginil, what would be your treatment? Patient is absolutely fit 60-year-old. What would you advocate? Radical prostatectomy or I know you will say I'll counsel both, but the patient says, what do you advise me to have? Ginil?
Unmute, Ginil. Yeah. Most important factor I check is how fit he is. He's a fit less than 75.
Yeah.
I'll prefer a radical prostatectomy by myself, but evidence is equal for surgery or radiation. Why I prefer is because I feel
I knew that you were going to say radical prostatectomy. That is fine. Anant, again the same question. 65-year-old fit guy. What would you advocate?
Localized radical prostatectomy, locally advanced radical radiotherapy.
This one, see, localized. Yeah, high risk localized based on next generation N0, M0, N0, M0. 78% said radiotherapy based. I was staggered by the number. I thought at least there would be 50-50 split. I knew that if I asked this question in India, it would be urology meeting, it will be 80% surgery to 30%. So this is from the APC. Yes.
In the recent consensus meeting.
Yes.
Okay, the same thing was, recorded. In that, 52% of them were medical oncologists.
Which one? This is from the APCC consensus.
Yeah.
This number is from the APCC consensus.
So how many were medical oncologists in that?
The medical oncologists, there are barely any surgeons. Out of the 120 or so, there are barely any surgeons.
Correct.
So, should you not distinguish between localized and locally advanced?
The reason they haven't differentiated that is you are not 100% sure with any investigation, isn't it? Is T3A localized or locally advanced?
It should be locally advanced.
Yeah. So then they've categorized 3A almost into high risk localized, 3B and 4 as advanced. And what do you use for the imaging? So that's the reason they are always has localized and locally advanced. So this was very high risk one going up to, and if you see 84% were radiotherapy based. Even in these, in younger cohorts, I would advocate surgery, but they didn't. And are we doing lymph node dissection whenever we do radical prostatectomy? Raghu?
I always do.
Okay. Raghunath?
Always do.
Okay. Can you expand on it? Why am I asking that question?
Whenever high risk is there, risk of having a nodal mets are high, I do extended lymphadenectomy. May not add to cure, but at least it will decide further adjuvant therapy.
Okay.
I can decide on adjuvant therapy.
Mainly for prognostication, you are doing it with a small probability that it might improve his survival.
Survival.
Am I saying that?
Yes.
Okay.
Yes. If the number of nodes are 1 or 2, probably it may add to survival.
So pelvic lymphadenectomy with respect to radical prostatectomy is mainly done for prognostic with a small probability that it might give a curative benefit. Okay.
Yes.
I'm not going to radiation. And let's say that this patient of yours, high risk patient, chooses radiotherapy. Now, are we irradiating the pelvic lymph nodes? Ginil?
Yeah, in our institution is a routine practice to irradiate the pelvic lymph node.
Raghavan?
Varies between the consultants. When
But
I
what
send
do
the
you
patient,
request?
when I send the patient, I request them to do that. Yes.
So that's the other one. So whenever a patient who has got high risk, localized or locally advanced is being referred or patient is going for radiotherapy, preferably request for whole pelvis radiotherapy. Okay. So take home messages: in low risk, AS is equivalent to active treatment. In low risk, yes. In intermediate risk, selected cohort, AS is an option. Watchful wait in elderly is acceptable, and substratify high risk prostate cancer. Sorry, I went over by 6 minutes. Thank you.
Thanks, Sanjay.
Thank you,
Thank you,
Sanjay.
Sanjay.
Thank you.
All yours.
Dr. Chandru.
Yeah. Raghunath sir, if you want to comment, brief 2 minutes, then I will conclude the session.
Nothing. It went very well.
Yeah.
Sanjay manages always a lot of learning points will be there.
Yes, yes.
So I thank all the speakers and the panelists for your inputs and enlightening us. Thank you.
So, dear audience, more than 70 audience are there. I thank Dr. Raghunath for selecting the appropriate speakers for this session. And only 10 minutes we have crossed, even though Raghunath was pushing time. But it's okay in online webinar. Those who are interested in whichever topic, they will do that. So I'm very happy the way speakers have conducted themselves. And of course, Sanjai Addla, very fast and furious. And localized, I was only confused at the end. Localized and locally advanced are the same. I got confused like Raghavan, but anyway, lot of take-home messages from Sanjay and all the speakers, except the video by Nikhil Vasudev. Rest of all the things we could do. Unfortunately, Prashanth in the last minute, his close relative got into the ER room, so he could not present about the diet. I was going through the diet. I was reading today about all the topics. Majority of the things we know, so we will not discuss further. I thank once again all the speakers and all the audience for sparing your valuable time on today. Next webinar will be on 22nd January. We are choosing on 3rd week Wednesday, so that it will be a pattern. Another interesting webinar will be on urethral stricture disease. This will be conducted by Dr. Vishwaroop as moderator. And I request all the juniors, please share your willingness to moderate, willingness to give a talk. Otherwise, we will be never knowing as secretary whether you are experienced or not, whether your area of interest also we will not be knowing. Our society is increasing. Aim is to get the juniors into the picture. So please convey the message to the ASU secretariat at the gmail.com or our personal WhatsApp number. We are continuously communicating. If you express your interest, we'll try to include in the next coming year in these type of seminars, because all of the juniors putting in one annual conference is very difficult. It is only 1.5 day, 2 days. So it is better you participate initially in the webinars, then share your knowledge, and then you can expect in the conferences. Thank you very much, all of you. Good night.
Chandru, one second. You can upload all these presentations to...
Yes, sir. We are uploading every presentation into YouTube from the day one of the this year academic year. So it automatically goes to the ASU YouTube. This link also given to the entire audience. Automatically same link will continue from the next hour.
Super.
Thank you very much, sir.
Thank you. Thank you. Thank you.
Thank you.